we are live in YouTube.
Now
We can begin.
Okay. So hello everyone. Good morning from Brazil. Good evening from Europe. Good morning from United States also. It's a great pleasure for me to introduce this webinar for the first time in Brazil. It was an honor when I received an email by Professor Garamond invited us to sharing this interesting topic. And I would like also to thank you, Hal Vorsilius from SoundClear, to organize with Professor Garamond this wonderful meeting that I hope that today we will discuss a very interesting topic. Ultrasound became very popular in general medicine and also in obstetrician. And then in neurosurgery today is a very interesting tool with different technologies, different machines and contrasts that we can perform our surgeries with much more quality than in the past. So I'm very proud to start in this webinar. And as you know, we have some lectures and then a practical demonstration of ultrasound. So now I will asking Ricardo Gap and also, of course, to thank you so much, the Brazilian Pediatric Neurosurgeon Society, for the support of this webinar. And as you know, we are on live in the YouTube channel. And Ricardo, please, it's a great pleasure to see you here.
Thank you, Ricardo. It's a great pleasure to me. On behalf of the Brazilian Society of Pediatric Neurosurgery, it's a great honor to be here and to have this opportunity to learn about this ultrasound. Ultrasound is a very interesting tool. It's growing in neurosurgical practice. So I think it will be a very, very interesting webinar. And I hope everyone enjoy it and learn so much. Thank you all the professors and thank you all the sponsors for this opportunity. So, Mateus, please go ahead.
Thank you very much. Welcome everybody. We will begin with Dr. Brian Ahead from Massachusetts General Hospital, who will speak about the overview of intraoperative imaging, comparing intraoperative ultrasound, CT, and MRI. Please, Dr. Nahed.
Well, thank you all. And I'm especially honored to present with this esteemed group on not only the use of ultrasound, but frankly, how it fits into the operating theater. And I've been particularly lucky to be part of this international group. And you can see the pictures there on the side of a group of individuals that are not only championing this, but hopefully trying to lower the bar by which we use ultrasound. I've been tasked with discussing intraoperative imaging, starting with my own transition from traditional intraoperative MRI and CAT scan, which we have and we use, to what I believe, and I'm sure everyone on this panel would agree, is the benefits of an intraoperative ultrasound and real-time imaging. Here are my disclosures. So I just want to put it in the context. We've been very, very lucky in the field of neurosurgery to have our counterparts working just as hard as us in neuro-oncology, neurology, movement disorders, radiation oncology, radiology, pathology. But it's really been these advances in the last several years, starting from decades ago to even in the last 5 or 10 years. Whether it's the operating microscope or advances in mapping or imaging or even intraoperative navigation, our field has advanced tremendously because of technology. And yet the thing that I find most exciting about the last 5 or 10 years has been the use of the intraoperative ultrasound. And hopefully I'll by the end of this talk, we'll be convinced that to use it in your practice. So when again, we all go into the operating room, we have dazzling images just like this, where you can see a lesion that's obviously identified, and it's so helpful to know its relationship to some of the functional spaces. Whether you're a mapping traditionalist or a functional MRI, there's no doubt that more information is better. If you add to that the fact that we're taking all this information and our craniotomies are now smaller than ever, this is like almost even a deep lesion. This is a pretty standard way to now take out tumors. So the less you expose, the better. And the only way you can do that is not only with better imaging before surgery, but certainly better imaging during surgery. And of course, everybody on this panel and everyone on the YouTube channel is using some type of navigation, I would hope. And it gives you the advantage of, again, finding the lesion, bringing technology into the operating room. And it's really that bridge between the technology before you get to the operating room and in it, which really gives you the advantage of using it. And of course, your eyes are probably the best aspect of it. But if you can just augment it, then the surgery might go a little better. So these are pictures of the intraoperative MRI and intraoperative CAT scan, as well as the ultrasound that we use at Mass General. Again, we're quite fortunate. We have an MRI split between 2 rooms. We're able to use it when we wish. More often than not, we use them for either functional cases or for lower grade gliomas. When this first started, I was using them in every single case. And over the last 15 years, I've switched to only using ultrasound, and I don't use MRI anymore. The CAT scans also, there's a lot of groups that use this, whether it's a traditional based, where it's, in this case, off a tracked system, or nowadays the ability to bring in a mobile unit. There's no doubt that there is value to real-time imaging and quick. All told, when we use the intraoperative MRI, it adds about 45 minutes to an hour, despite being very good at all the mechanisms. You can imagine all the things that have to be removed from an operating room, but the images are great. CAT scans are a little bit easier because you aren't worried about the magnetic aspect of it, but it still does involve making the field sterile, and therefore a lot of workflow issues with these two on the left. The ultrasound, it's real time, whether you're using the BK, the Eloka, or whatever your ultrasound use is. The fact that you can take a wand and put it in real time and continually use it without stepping out of the field is certainly advantageous. Now, when the intraoperative MRI first came out, there were a lot of studies that came that showed the benefit of it. And it's pretty obvious, right? If you're looking at a lesion such as this, a non-enhancing lesion, it's in some eloquent cortex, you can see that if somebody takes it out, sometimes there'll be a little bit of residual. And these surgical adjuncts, whether you use some type of fluorescence or in this case, an intraoperative MRI, allow you to not leave some of the stuff along the boundary, and therefore get an intraoperative MRI and then ultimately go back and remove that lesion. Obviously, that is a significant benefit if this is an issue for you. And again, the Kaplan-Meil's survival curves are very obvious and very beneficial, because it's really extent of resection. And that's all we're talking about, is how can we be aggressive and yet safe. But I would argue that that same value in getting the intraoperative MRI can be done with an intraoperative ultrasound. So on the left here, you see the same image. This is a cystic tumor here, enhancing on the superficial aspect of it. There's a deep cystic quality to it. This is what we're used to in terms of looking at a coronal. Certainly, if you are a little more in tune with your navigation, you could even use inline 1 and 2 as you come along, or the probe's eye view, and come along the trajectory and target the lesion, maybe deal with the cyst if you're going to. But if you look at that same image intraoperatively, you actually see a little more clarity by the use of the ultrasound. In this case, you can see different aspects within the cyst where you don't really appreciate them on the MRI. You can look at the boundary between the cyst and the brain. Often you can see the difference between edema or even very densely adherent or invasive tumors. And it becomes quite beneficial, particularly in some of the harder tumors, because you can not only get this image before you start, but more importantly, while you're resecting. Here's another great example. This is from our use of or the use of a BK ultrasound. In this case, what you're seeing, for those who aren't familiar with the ultrasound use, you see essentially the probe. This little space is the fluid above the in this case, it's irrigant. You can see the tumor on either side and then the obvious mass, which is just draped around here. Now, when I look at this, I don't look at just the tumor. I'm looking at the relationship of the brain, the relationship of sulci, the relationship of any other structure that makes it more obvious. And in fact, when I teach it to our either residents or at courses, the key is to look at the object in relationship to its neighboring structures, which makes it a lot easier to use, particularly as you're no longer looking at it in a traditional axial coronal sagittal, but sometimes a cross-dimensional view. Now, in this case, the tumor was taken out. There was a nice clean plane, and you can see, in fact, the boundary of it is very obviously no more tumor or no more tumors involved. There's been a little bit of work on how to make and define these borders, because you can imagine in this case, this little bright spot to the untrained eye looks concerning, but to the trained eye looks like just a normal amount of postoperative changes that happen. Now, if you have a layer of blood, anything that can interfere with the ultrasound image, it does make the complexity a little bit more difficult. If you've got stuff like Surgiflow, Surgicel, whatever adjunct you use, it does make things a little more difficult. And then frankly, just keeping the irrigant in the field so that you can get a nice field, a nice view, it can sometimes be quite difficult. But yet we use it, and we use it in every one of our cases. Now, that's the structural use of it. And again, it's actually a functionally amazing tool. And I would say that in neurosurgery, we have a lot to learn from the other specialties, whether it's OB, whether it's anesthesia, who are using it to identify vessels and the relationship of placing something safer. This is a great example of a very, very vascular tumor, as you can see here with the Doppler flow of it. Now, again, the flow is seen not only in this cascade of colors, but also the relationship of the vessels that are, you can't see through this plane, but feeding this. And so you can almost target, whether you're using navigation, your surgical hunch, or in this case, the ultrasound, you can find the feeding vessel and target it before you attack the tumor. You can also ensure that there's no more, in this case, angioblastoma, no more evidence of a tumor that's residual. And so, we started with that intraoperative MRI, and we started with that ability to say, okay, well, is it useful? And yes, certainly any type of imaging is useful, even in the best of hands for people who do this all the time. This is a great example of the use and the potential use for an ultrasound. So it's a very deep-seated tumor. There's different aspects of it. It's very heterogeneous. Obviously, the goal is to remove it all. And this is what it looks like in the intraoperative MRI, or in the intraoperative ultrasound. What you can see is, again, what I look at is the relationship of the brain, the widened sulcus around it, some of the edematous aspects of it, but really this brain tumor interface, which in real time is just a swap of a hand. And by picking up different aspects of the tumor, the relationship of the tumor, you can truly find this boundary when you're dissecting, and therefore maintain a nice gross total resection. Now here, what you can see just again, not that the surgery was stopped at this point, but rather captured. So you can see, again, there's a cystic aspect of it from what was removed. You can see a layer of blood, which is this bright spot. And then ultimately this part of the mass, which is this part of the mass, is left over. Now, to the untrained eye, this is very difficult to read, but after you do a number of these, you start to realize that this is the relationship of the tentorium, cerebellum below, and you can almost see that distance is maintained. And so as you're moving through, you use those reference points to not only help you, but also the relationship of the brain, the relationship of the cell side become fingerprints by which you can use and almost guide marks for you to take out tumor. I found this an incredibly useful tool. Again, it's replaced my use of intraoperative MRI and CT, and we use it whether we're doing a large craniotomy or a smaller, very minimally invasive one. The power of it is real-time imaging, which I think the other adjuncts are great, but they really are one and done. Where you get it, you have to then interpret the data, and it's very hard to get it again after you're doing it. So ultimately, every OR has a significant amount of technology. Some of it very expensive, some of it hard to get, some of it may not even be available. This is very similar. This is taken from BrainLab, but if you can see, we have our navigation, we've got a monitor, and this is how I set it up. I set up the ultrasound right next to me, and the probes just come up as we're able to operate. And we use them in tandem. Now, there have been a number of different great connections of tying your navigation to the digital image from the ultrasound. And that makes it sometimes easier or a lower bar to use. But ultimately, it's this idea of it's a whole host of suite of technology that you bring into the operating room to then help you carry on the surgery, and not only carry it on, but do it successfully and actually leave the operating room with a best understanding that I've done what I've sought out to do, take out all the tumor, remove the lesion, whatever it is. And to me, there's nothing better than seeing it on an ultrasound. With that, I'll turn it back to the panel. Thank you again for the invitation. I look forward to the rest of the day.
Thank you very much, Dr. Nahed, for this wonderful presentation. Now,
Matheus, just a comment. We have a time to discuss at the end of the lectures, and we'll follow with all the lectures, and then in the end we can discuss everyone. Okay.
Okay. So thank you, Dr. Nahed. So now I will present Dr. Moyadi. Dr. Moyadi from Tata Memorial Center, India, who will present about mastering in intraoperative IoUS skills required and practical guidance. Please, Dr. Moyadi, up to you.
Checking whether you can hear me and see my screen.
Not yet.
Not yet.
Yeah.
Not yet. Try again.
Okay. Okay, and I'll stop and try again. How about now?
No.
No.
Maybe your connection.
Yeah. Okay, that's strange.
No, now it's okay.
No, it's okay.
Now it's okay. Okay. Just to
Yeah.
click. Yeah, click on presentation view. On the
Yeah,
right.
I did that. Can you see it now? Full screen?
It's not full screen yet.
Yeah.
Not yet.
Not yet.
Okay. Let me just once more. And
Okay. Okay. Now it's
full
okay.
screen.
Now it's full.
now you can see it full screen.
No, now it's outside. We can't see your screen.
I think we are having a delay.
Yeah.
Okay. So is that okay now? Because I can see it full screen, but
Yeah.
you're not seeing
Yeah.
it.
Now it's okay.
Now it's okay.
Okay, fine. Then I can start.
Yes. Go
Okay.
on.
All right. Sorry for that. And I think thank you, Ricardo, for this opportunity to speak at this symposium. These are my disclosures. What we've heard from Brian was nicely summed up the need for intraoperative imaging in neuro-oncology and glioma surgery more specifically, is that the ultrasound is actually a very useful and multi-purpose tool in the operating room. And Brian has showed that it can be used for various stages of the surgery. And this has evolved over the years since the ultrasound was introduced into the operating room many, many years back. In fact, it was the first intraoperative imaging tool for the neurosurgeons. However, those days, there were cumbersome machines and probes, all of which led to difficulties in acquiring the scan and interpreting images. However, we've come a long way since. Machines nowadays are much better customized for neurosurgical purposes with specifically designed probes. And this has resulted in a resurgence of intraoperative ultrasound as an imaging tool. Brian showed some wonderful images, and you can see from this collection of images that the resolution of images provided by the ultrasound can be quite exquisite. Could match the MRI in most cases, and sometimes may even be better. And the scope of application is not just restricted to cranial, but we could have functional imaging and spinal imaging. And you'll see that in the course of this symposium that there are many other aspects to intraoperative ultrasound. At the core of the utility of the intraoperative ultrasound is the ability to get a good ultrasound image, because your subsequent interpretation and intervention based on that image will depend on how good a quality that image has. And this has been shown in this paper published some years back, of course, by Dr. Unskad's group. This is more important when you use the ultrasound section control tool, where you have to interpret the image at the end of the surgery in the presence of artifacts, which of course need to be minimized and avoided. The challenges with are the unconventional plane of imaging. In the absence of the full head view, we're all accustomed to seeing full head views of the MRI, and this leads to a lack of image orientation. And this becomes a problem when you want to resolve spatially very small residue, and also a problem when you want to temporally, over a period of time, compare serial 2D ultrasound images. The solution for overcoming a lot of these challenges, one of the solutions is to combine the ultrasound with navigation. And this gives you the opportunity to improve orientation, improve the full head view. And this is what the ultrasound is all about. Regardless of whether it's 2D or 3D ultrasound, if you compare it with intraoperative MRI, of course, the image resolution of the MRI is far superior, and I think there's no debate about that. The orientation of the surgical field is also very good, and that's because of the full head view and the traditional axial coronal imaging planes that we are all used to. But if combined with navigation, the ultrasound can also provide that. However, the ultrasound actually proves beneficial is that it is very quick. It can be done repetitively without interfering with the workflow of the surgery too much. And it can be done at a fraction of the cost. And with the newer machines, the newer probes, and the improved image resolution, it actually may prove more beneficial than the intraoperative MRI practically. In our own experience, we found it very useful across the spectrum of tumors, be it diagnostic sampling via biopsy or resection control. In our cumulative experience, we've used both 2D and 3D ultrasound. And what we've seen over a decade is that 2D ultrasound in our hands and in our department is the more common use of the ultrasound. For resection control, we prefer using 3D ultrasound. And the reason being that when you use control tool, the problems with orientation and temporal correlation of serial scans is very important. And when we've used this, the intermediate scans have more often than not prompted us to go ahead with further resection of what we thought was a complete resection. Inadvertent misses or inadvertently missed residues can be detected, leading to a better diagnostic accuracy and comparable GTR rates when you look at MRI-defined gold standard. Moreover, it actually fits in very nicely with the multimodal strategy that we all employ in gliomas, be it fluorescence guidance or awake surgery or mapping and monitoring. And there is very little interference, and it's very synergistic with all these kind of technologies. So if you look at ultrasound, it fits in with image-guided surgery, integrating well with navigation. And whether you use 2D ultrasound with or without navigation, each of them has their own strengths and limitations. When combined together, you have much more benefit and utility. However, in order to extract the potential and the benefit of the ultrasound, you still need to be able to get the good scan and interpret it well. And that is the challenge, and that's the basic skill that you need to master as a neurosurgeon. These problems of the ultrasound can potentially tilt the balance of benefit away if it's not applied and used correctly. And that's where you need to get trained and improve in your ultrasound acquisition and interpretation. In order to understand what factors influence these challenges, or what factors contribute to the challenges which neurosurgeons encounter, we conducted a survey a couple of years back when our group did this international course on intraoperative ultrasound. And what we identified that there are certain hurdles which surgeons encounter. A lot of them are to do with the technical difficulty in understanding the machine and the probes. And these in turn affect the acquisition of the scan as well as the interpretation. And coupled with the lack of knowledge of surgeons in preparing the stage, so to say, during surgery for a good ultrasound scan, compound the problem of image interpretation. Often tumor characteristics also add to that dilemma. And therefore the basic skills or the basic competencies that one must acquire in order to do a successful ultrasound intervention is to have a good ultrasound scan, acquirable scan, and to interpret the image well. These are the core competencies. And when you define a competency, it's actually a sum of the innate ability or attribute of a person, which can then be honed on the basis of the knowledge and the practical skill sets that one acquires. And with regards to these two basic competencies, which we defined for getting a good ultrasound scan, these are the skill sets and the knowledge base that is important to be acquired in order to master intraoperative ultrasound. Of course, the basic ability, innate attribute of a person are important, but with adequate training over a period of time, these competencies can be perfected. What are these practical skill sets and the theoretical knowledge that one needs to know for performing a good ultrasound scan? These are important because these can be developed in a modular fashion by training, and if performed correctly in a sequential stepwise manner, they would lead to performing a good and an optimal ultrasound imaging. How do we acquire these competencies? One of the ways to do that is by practical hands-on workshops and courses, not necessarily in a formal course, but it can even be done in your respective departments. This is how we have done our workshops as a group. There are phantoms available commercially as well as phantoms that you can make in order to practice and develop each of these competencies. At the same time, image interpretation is very, very important. In order to do that, as I showed you, navigated ultrasound to improve your ultrasound image interpretation skills, and over a period to not need the MRI to interpret the ultrasound. However, as a training exercise, it's good to have ultrasound and MRI images in an atlas-based manner to improve the image interpretation. And then, of course, you have a very, very potentially useful and important learning tool is simulation. And I would not talk about this because Alessandro will be presenting and you will be doing some simulation at the end of this symposium. And finally, the most important, and I think according to me, the best way to learn the ultrasound is to do it during surgery. And to do it day in and day out for all surgeries that you do, even if it does not actually require the ultrasound, because doing the ultrasound is not going to take too much time. But in the process, you're going to hone your skills to a level of perfection such that in a case where you really require it, you would not struggle. This starts with setting up the operating room with the ultrasound positioned in a way which is easily accessible, because you would be the person who is operating it rather than have a third person or a radiologist do it. I prefer it that way, and I think that is the right way to do it. It also involves understanding the different probes available, selecting the right probe, planning the craniotomy, the position of the patient, the adequacy of the craniotomy, and the technique of preferably using two orthogonal planes such that you cover a wide volume of 3D ultrasound anatomy and make a mental picture of that. Then adjusting the parameters on the ultrasound scanner so as to get the best image available, and to be able to then interpret the image that you get so that not only the tumor, but surrounding landmarks, as well as important critical neurovascular structures. At the end of the resection, you also need to be able to perform a good scan. Remember, I said that you have to have a good quality of the image. You have to avoid and minimize artifacts. Defining the residue vis-a-vis artifacts is very crucial in order to avoid false negatives and false positives, and to understand the importance of doing serial scans and special strategies and techniques of acquiring scans either through the cavity or through the surrounding brain, and using special techniques, and you'll hear more of these in the next few talks, in order to identify artifacts and then minimize them so as to get the best result from your surgical intervention. So if we were to compare and sum up what are the skills and the ways in which we can develop these, I would say that live surgery, initially mentored by a more experienced user and then subsequently doing it yourself repetitively, is probably the best way to understand and to be able to optimize your ultrasound acquisition and interpretation. And then a combination of practical training, hands-on based on phantom models, combined with simulation-based training would help you acquire the necessary skills both for ultrasound acquisition as well as for image interpretation. These skills are important because to bridge the gap between your good-hearted, good-natured intent and the actual outcome, you have to be adequately trained. And this is the reason why we conduct these kind of symposia and practical workshops. We've done workshops in the past, very recently in Barcelona, and we have workshops coming up at different places across the globe in the near future. And I hope more and more people get trained in ultrasound, acquiring these basic skills so that the best optimum use of the multiple and the unlimited potential of the ultrasound can be realized. Thank you very much.
Thank you very much. So as like Ricardo said, we will have some time to discuss after the presentation. So now, unfortunately, Dr. Dimeco could not be here with us. So Dr. Perrin will present a 2D ultrasound and resection of brain tumors, imaging interpretation and anatomic landmarks. Dr. Perrin, here?
Hello everyone.
Dr. Perrin is neurosurgeon at Neurological Institute of CEUS in Milan, scientific director of the Neuroscience Center, and adjunct professor in molecular neuro-oncology at the University of Trieste. Please, Dr. Perrin, go on.
Thank you very much. So I do apologize, but Dr. Dimeco couldn't make it because of some unexpected circumstances, and I will take care of presenting his work, his presentation, which will cover basically some very practical aspects, hands-on suggestions for those of you interested in approaching the world of intraoperative ultrasound in neurosurgery. So I don't want to repeat what the other speakers already alluded to and already mentioned during their presentations. But the key point is that ultrasound has become very popular during the last years, as you can also see by measuring the number of publications per year that came out regarding this topic. One of the reasons is the fact that technologically ultrasound devices are managed to reach a very high degree of quality, also in the quality of the images that are produced by these probes and devices. Also, we believe that the reason why neurosurgeons like it so much is that it's the only real-time imaging technique that we have in the OR. Magnetic resonance is actually an early post-op or something that would put an interruption in the flow of your surgery. This is the only dynamic, real-time, and inexpensive technique that we have. Actually, as a matter of fact, at CBESTA, for all of our neuro-oncology cases, we use it, and we use it extensively, like many, many times during every case. And it's a back and forth way of operating with the probe always in our hands. Something that is not easy, and it's still limiting the use of intraoperative ultrasound, is how to interpret this image. So by means of coplanar preoperative MRI, as you can see, everything becomes easy. So if you have the chance of having a matched coplanar MRI image to your intraoperative ultrasound, you can actually tell quite easily what is what. And this is something that we have with our IoUS navigation system. So the ability of having dynamic coplanar matching of images, intraoperative ultrasound and preoperative MRI. So that helps a lot. Also, the newbies, people who face this technique for the first time. So some tips that we would like to share with you before starting your resection. So take advantage of everything you have. So neuronavigation, MRI is important. Try to match that with your intraoperative ultrasound images and try to get familiar with that and understand and decipher what is what beforehand. Then start, as Aliasgar mentioned, using orthogonal planes. So use coronal, axial, sagittal planes, something that we're all familiar with as neurosurgeons, and something that matches with the preoperative MRI. Move the US probe as much as you can. So get familiar with that. Don't be shy. Use it as much as you can during all of your cases that you operate. Find the target. It's always important because it's something very easy to do. Like you have to find the tumor, find the lesion inside the brain and grasp to that and start from there and move to something more complicated like normal anatomy. And then adjust for brain shift that might happen once you open the dura or once you remove the scalp. So I'll give you some examples. So these are some scans along the axial plane, as you can see. This is something that you can do on the coronal plane. And when you have shift brain shift, like in this case, you see. So preoperative MRI and intraoperative ultrasound do not match. So you can grasp the image and move them and align them so that you can correct for brain shift anytime you need it. Some other additional features that you have when you do use intraoperative ultrasound, like Doppler, elastosonography, that I will not dwell so much because I know that Francisco Prada will mention it extensively, and intraoperative ultrasound. So Doppler is quite useful, especially in this case. So frontal glioma with the marginal callosal artery in Dove, at the end of your procedure, it's nice to see whether you still have flow in the within your arteries. Elastosonography, we published many papers on that, and Francisco will mention that extensively, so I'm going to skip. So contrast enhanced ultrasound. So this is a nice view of São Paulo in Brazil. It's a night view. It's black and white. It's like B mode. When you add contrast enhanced, that's what you get. So you add color to your scans, and plus you add tons of information. Like what? Like you can get a better grasp, a better understanding of normal anatomy and tumor anatomy by better visualizing the vessels and the way the tumor is perfused. You see, it's different as compared to normal brain. And thanks to that, we managed to get to a classification of intrinsic brain tumors. And you can see that the pattern of vascularization and perfusion is different when you move from low grade to high grade gliomas. Angiosonography is a special feature of contrast enhanced ultrasound, and its ability, like in this case, to visualize the circle of Willis quite nicely, and that was published again. So you can exploit intraoperative ultrasound and get many informations depending on what you're doing and what you want to do in that specific case by combining B mode, contrast enhanced ultrasound, Doppler, and elastosonography. Something very useful and very important about contrast enhanced is the ability of detecting a tumor remnant. As a matter of fact, now contrast enhanced, contrast medium is allowed and is recommended by the European Association for the use of intraoperative ultrasound. And it's something that you must be aware. So you are allowed to use contrast medium for your neuro-oncology cases. So that was something that you can do before tumor resection, but once you start resecting your tumor, you can take advantage of that, as I mentioned many times. So you can take your probe and bring it in your operative field as many times as you want. And again, do not use B mode only. Use all the technologies and all the methodologies that you can. So like in this case, that was the tumor, and we wanted to control whether at the end we were not sure whether this was a remnant or not. Actually, it was a remnant. So we combined intraoperative ultrasound with contrast medium injection and with 5-ALA. So by combining all of this technology, we were absolutely sure that that was a tumor remnant, and we continue our resection, achieving a complete resection for that tumor. So something very practical. When you use intraoperative ultrasound, do not use oxidized cellulose during your surgical resection. So mind you that once you use it, you will get some artifacts that want to prevent you to get optimal images with your intraoperative ultrasound probe. So use it only at the end of your resection. Always irrigate when you use intraoperative ultrasound and the probe is in the cavity. So fill the resection cavity, get rid of the blood that prevents it from getting a clear view. Use the linear probe on the margin of your surgical cavity. So try to put it exactly there, like on your normal brain, so that you get rid of some artifacts. And when you want to look inside the cavity, use the convex, like the small probe, put it inside, and that will get you a better view of your cavity and, if any, of your tumor remnant. That is something that will mention Professor Unskat, so I will not dwell on it. And this is something we developed recently, this ultrasound transparent bone probe that you can use at the end of your resection. So the idea would be, if you put this probe that is transparent to ultrasound, will you be able to watch and follow up on your patients in your outpatient clinics? So our preliminary results are quite encouraging because, as you can see, we managed to achieve good quality B-mode images on a live patient in our outpatient clinic. And the contrast injection can be achieved, and you can get better images thanks to that. Doppler can also be implemented through this bone probe. Another special feature is the ability, thanks to a very tiny probe developed by BK, the ability, for instance, to follow your EVD as it is placed inside the brain of your patient, follow the trajectory and see when the tip enters the ventricle. So some other features that you might want to be interested in. And so you see how flexible intraoperative ultrasound is. So not just for oncology cases, but also for this case, to guide and measure how precise you are in positioning your probe inside the ventricle. So there are some downsides. It's not easy to become a master in interpreting the intraoperative ultrasound images because it is operator dependent. You are facing some unusual imaging, and also the orientation is not conventional for neurosurgeons. So it takes time to get familiar, as Eliaskar was saying. So you need specific training. This is something we are providing with our courses all over the world. And they are very well received, both by faculty and also by participants. We also develop an app that you can use easily, and it's something that transforms basically your smartphone into a virtual US probe. And this is something that we are going to do at the end of this course. So I invite all of you to register on this portal, which is Neurostream Academy. So that's the web address. So if you haven't done so, go to neurostream.academy, register so that you have your credentials. And at the end of this course, we will have a chance to do some real simulation of intraoperative ultrasound just by using your smartphone and your laptop. So thank you, everyone.
Thank you very much, Dr. Perin, for the presentation. And I sent the link to everybody in our YouTube channel again here. So please register in advance to the simulation in the end of the symposium. So now I want to present Dr. Ansgaard. Please, Dr. Carmon, who will speak about experience from everyday use of navigated 3D US in tumor operation. Dr. Ansgaard, sorry about my pronunciation, Dr. Ansgaard, is Professor Emeritus of Neurosurgery at Norwegian University of Science and Technology.
Thank you very much for the nice introduction. I have a disclosure medical advisor for Sonoclear. I have used navigated 3D ultrasound since 1996. I have used this equipment, Sono 1, which is an ultrasound equipment with the integrated navigation. When we built our new neurocenter, we had the chance to get an intraoperative MR, but we decided to use the 3D ultrasound because it's a flexible and inexpensive solution that met our needs. It has a very low capital cost, no imaging hazard. It takes only 30 seconds to acquire a scan, and the soft tissue quality is usually very good. One challenge is that learning is needed to benefit from intraoperative ultrasound, as had been mentioned several times. And that's the reason why we have these courses. And that's the reason why I used to have these training courses in Trondheim. This is from one of these courses, live operation that is with transmission to the auditorium. This is a rather young lady with low-grade glioma immediately in front of the precentral gyrus. This is from 3D ultrasound acquisition of the tumor. You see the tumor very well. And then when we make the biopsy, you see already at that time the pre-op navigated MR is way out of range. So the only thing to trust is the ultrasound. And that is because of the brain shift that already has occurred. And I like to use navigated CEUS in my operation. In that way, I will know the tip, exactly where the tip of the CEUS is located, and can see the distance from the tip of the CEUS to the border of the tumor. Different stadium of the operation, and at the end, gross total resection in 2 different planes here. That was confirmed with MR 1 day after the operation. The patient had a small temporary paresis in right hand due to this ischemic lesion in the precentral gyrus, but it fortunately normalized in a week. The most important point for ultrasound-guided operation is the image quality. And as has been mentioned at the start of the operation, it's easy to obtain ultrasound image quality that is just as good as MR, as you can see here, by comparing pre-op navigated MR with intraoperative ultrasound, low-grade glioma, another low-grade glioma, and then high-grade glioma, another case. It's more challenging to keep the high quality during and towards the end of resection. And of course, what is important, then several requirements that we have to take care of. Horizontal craniotomy, optimal positioning of the patient to obtain that. In my experience with supratentorial tumors, you can always obtain more or less horizontal craniotomy. The most challenging is immediately in front of the central sulcus, where you need supine position with a flex neck and sometimes also a flex back. And also behind the central sulcus, where a modified park bench will do. And as has been mentioned, you have to obtain hemostasis, you have to remove spatulas and surgical patties, you have to have a clean cavity when you are acquired images. Ultrasound and navigated pre-op MR have different strength and qualities and limitations in a way. And navigated pre-op MR has a large overview and I would say lousy accuracy. And intraoperative ultrasound has a high accuracy and a limited overview. And this overview of the MR and the accuracy of the ultrasound can be combined by navigated 3D ultrasound. You have a probe with a navigated probe that you move over the area of interest, and then the system creates a 3D volume that is fused into the pre-op navigated MR volume. And this has several benefits. You can immediately register the brain shift. And here, this could be an artifact from the cyst, this signal here, but by comparing to a cross-section from the navigated pre-op MR, you see that this is also a tumor. Another benefit by 3D ultrasound is that you can follow the resection and know at any time how much tumor tissue is left. This is a low-grade glioma. Enhancement artifacts can be a big problem for ultrasound image interpretation. And 3D ultrasound recordings may help to reduce this problem. Here you see a very strong enhancement artifact. This is a low-grade glioma where you have removed most of the tumor, still some tumor tissue left. And here, everything should have been removed, but you have this signal here. What is it? By comparing to the previous image, you will immediately know that this is a new signal. It's an enhancement artifact. There are several ways of dealing with these enhancement artifacts. One way of doing it is to use small high-frequency probe that you put in the cavity. That will reduce the distance from the probe to the cavity wall, and that will reduce the noise. But there are some disadvantages. You have a reduced field of view, it's cumbersome to use, and it has the potential risk of harming tissue by manipulating a probe into the cavity. A more elegant way of doing it is to use acoustic coupling fluid that has the same damping effect as the tissue. The attenuation coefficient is in water is very low, while the attenuation coefficient in brain tumor tissue and also normal brain tissue is very high. And this creates this chaotic signal at the bottom of this ringer-filled cavity that makes it impossible to interpret the ultrasound image. And by filling the cavity with acoustic coupling fluid, you will immediately see tumor borders here and see that this tumor goes down to the ventricle. I have used this acoustic coupling fluid in a phase 1 technical and safety study of 15 glioblastoma patients. The adverse events in this study were within the limits of what have been reported in other glioblastoma publications. And as for the quality of the images, we presented a pair of images, one with ringer and the other with acoustic coupling fluid, to 5 independent neurosurgeons in a blinded and randomized way, and asked them to score the images. And the quality of the images were highly in favor of the acoustic coupling fluid. A couple of examples. This is a glioblastoma along the falx and the corpus callosum in axial and sagittal view. And towards the end of resection with ringer in the cavity, it's very difficult to interpret the ultrasound image. By filling the cavity with acoustic coupling fluid, you can see this residual tumor, and you can see that everything is removed along the corpus callosum. Another case, an occipital glioblastoma. After having removed part of the tumor, I did a new image with ringer in the cavity. It's easy to see the tumor on the probe side. On the other side of the cavity, it's impossible to interpret the image. And by filling the cavity with acoustic coupling fluid, you can see this satellite tumor, and you can see that there is some tumor tissue underneath the falx. And here is how it looked at the end of surgery. Intraoperative MRI is the current gold standard of intraoperative imaging. We believe that with, at least I believe that ultrasound combined with this acoustic fluid could be a new gold standard for intraoperative imaging. As I said, I like to use navigated ultrasound aspirator in my operations, especially in cases where the tumor is below an intact normal cortex, like in some insular gliomas. This is a small insular tumor on the left side. See the tumor here. Most neurosurgeons will operate this through a transsylvian approach. I think it's more elegant to do it through a transcortical resection guided by navigated 3D ultrasound. Then you can do it through a very small opening in the cortex. And you can use 3D ultrasound angiography to help localize the insular vessels. And you can operate the navigated CEUS in between these insular vessels and gradually remove more and more of the tumor. And at the end, everything is removed and you see the vessels hanging freely in the cavity. And the patient was, this was on the dominant side, and the patient was very well already a few hours after the operation. Gross total resection, and everything was done through this small opening in the cortex. Navigated CEUS is especially useful in deep-seated lesions with narrow excess. These are two young men with tumors in the amygdala region, one on the right side and the other on the left side. This patient B had been operated on at another university clinic. They had tried to reach the tumor through a transsylvian approach, and this is the scar from that operation. They didn't reach the tumor, so they sent him to me to do ultrasound-guided operation. These are MR 1 day after operation, gross total resection on both of these tumors. Patient B, and no neurological deficit, but patient B had a hardly noticeable paraphasia. This is the way I do it, temporal linear incision, and then a craniotomy as far down to the zygomatic arch as possible, and then try to go through the temporal lobe as low down as possible to reach the tumor. And this is the ultrasound image before start of resection. After having resected part of the tumor, you see the cavity, the operation channel is very, very, very narrow. And then at the end, where everything is removed. All my low-grade glioma operations were done with the patients asleep, but it's easy to combine navigated 3D ultrasound with wake operations, has been shown by Mayadi and Steno in these two papers. So to the results of ultrasound-guided low-grade glioma operations. Some of you might have heard about this study we did in Norway, where we compared the results of low-grade glioma handling in two university clinics in Norway, one with the strategy favoring early surgical resection, and the other with the strategy doing biopsy and watchful waiting. The first author, Jakola, was the PhD student of mine at the time, and I was the one that did the early resection by 3D ultrasound guidance. This study was possible because of the organization of the healthcare in Norway. Free healthcare, regional organization, so you got a randomization in a way by postcode. And all patients in this study were included, also those that did not, that had a grade 2, also patients with that was not operated. So it's a rather robust material. The median survival of our patients was 14.4 years, much shorter at the other university clinic, of course. But what was very important is that the adverse events in the primary handling of these patients, where we compared early radical resection and primary biopsy was not different. It was the same. Another PhD student looked at my material from 2008 to 2015. This is also a robust material because I tried to remove as much as possible of tumor material, also in clearly absolutely inoperable or tumors that were impossible to remove gross total. So the median resection grade was 93, gross total resection 30%, the median residual volume 1 milliliter, and the quality of life was maintained or improved in 86%. So in conclusion, 3D ultrasound-guided low-grade glioma resections under a general anesthesia is a safe procedure, and extent of resection is consistent with published studies using other advanced neurosurgical tools. Thank you.
Thank you very much, Dr. Gamond. We are ahead of our schedule. And let's proceed with the next presentation with Dr. Prada. Are you here?
Yes, I'm here.
Dr. Prada will speak about intraoperative multi-parametric ultrasound in neurosurgery. Dr. Prada is neurosurgeon at Istituto Neurologico Bista, Milan, Italy, and director of the Acoustic Neuroimaging and Therapy Lab.
Do you see my screen?
Okay, but it's not full screen yet, Professor.
How is it now?
Okay.
Okay.
Thank you.
Awesome. Everyone, hello everyone, and thank you for the introduction, for having me here. So I will follow the discussion about the use of ultrasound during surgery, and I will try to highlight how this is. I mean, this has been already discussed how versatile ultrasound is, but really it's a multimodal imaging, and I would like to focus on contrast-enhanced ultrasound and show how this can enhance our understanding of the physiopathology during surgery. So these are my disclosures. So basically, multi-parametric ultrasound is defined as the use of these different ultrasound modalities. And actually, it's becoming the gold standard for many specialties. Here are a couple of examples in urology or for vascular assessment. But really, it's a multimodal tool, and this can offer multiple information in real time. And we have all these options in our OR, if assuming that we have a last generation ultrasound machine, which in any case is much more, it's much less expensive than other imaging modalities, for example, the MRI, or it's probably even cheaper than a navigation system alone. So, and this is an example of what we can achieve. So this is a B-mode only image of a frontal glioma, and it has been highlighted by the presenter before me. We can use Doppler to see the vessels. We can use microbubbles to see the perfusion of the image of the lesion, or another modality is elastography, but there are others as well. And with elastography, we can assess the stiffness And the concept is similar to the use of MRI. So this is a T1 MR. Of course, no one will perform surgery relying only on this image, but we would like to have contrast. We will ask for a T2, for a flare, and also we can have also a functional MR or DTI, and we are getting there with ultrasound as well. So this is an example of how we can visualize in different, how we can achieve different and obtain different information in a case of a glioblastoma. So we have the B mode here. Then we can visualize the vessels and we can measure the flow. So we can assess which vessel is an artery and which vessel is a vein in the surrounding areas. We can visualize the microcirculation surrounding the tumor. We can assess the perfusion here with the microbubbles. And we can assess the stiffness with a large field of view in a qualitative manner, and also we can measure the elasticity model of the tissues using the shear wave elastography. So in order to achieve all this image, as it has been mentioned earlier, it takes, once you are become practical with it, it really takes 5 to 10 minutes to obtain all these informations. And also the interest opportunity offered by multi-parametric ultrasound, it is that it helps to overcome one of the drawbacks of ultrasound, which is being operator dependent, because we can obtain quantitative information. So we can correlate numbers to a certain image that we obtain. So we're moving towards probably a standardization of ultrasound. So for the sake of brevity, I will focus only on contrast enhanced ultrasound as one of the tools for multi-parametric ultrasound. This is a picture and a video of the microbubbles, which are very interesting because they have been developed for imaging, but they are now used also for therapy, and we will discuss it briefly at the end of the talk. So basically, the microbubbles, when they are hit by the ultrasound, they start to resonate. So they give back a signal which is specific to the microbubble, and actually they allow to perform a real-time angiography. It's angiosonography actually, and we can visualize both the highlight, both the micro and macro circulation at the same time, as well as the degree of perfusion. Their use has been extensively studied in all organs, and their use is regulated by guidelines. These are the guidelines from the European Federation for Ultrasound in Medicine and Biology. And also the first attempt, it's not a new imaging modality in neurosurgery, since the first studies date back from the early 2000s, and the studies were performed in Japan. The first one was Professor Canno. And as Alessandro Perin showed earlier, we can really highlight different structure. Here you can see how we can highlight the tumor, which is a frontal metastasis, but we also are able to highlight the surrounding vessels. As you can see, the anterior circulation and also the microcirculation. And this has advantages over the Doppler because we don't have to change the angle of insonation. We don't have to change the sensibility. Actually, we just need to inject the microbubble intravenously at the time of the examination and start a specific algorithm, start a specific modality on the ultrasound machine. So your machine needs to be equipped with the contrast enhanced ultrasound, as well as the other multi-parametric imaging modalities. This is a picture of the polygon of Willis through a temporal approach for an epidermoid, and you can see that it really shows in detail the arterial circulation, and we can go really deep and even contralaterally. With contrast ultrasound, it's possible to visualize different kind of tumors. So here we have all the gliomas, different kind of tumors such as pituitary adenoma, angioblastoma, ependymoma, and as long as they have a higher perfusion compared to the parenchyma, they are really highlighted. So it is really capable of enhancing the visualization of the lesion that we can obtain with B-mode. These are other group of tumors such as metastasis, meningioma, and interestingly, we are also able to assess the histology in a glioma case according to the degree of vascularization. And we are able to visualize clearly the radiation necrosis, because it doesn't not having a microcirculation, microbubbles do not circulate, and they appear as a black spot. So it's a sort of negative of the lesion. The microbubbles are helpful also in assessing the resection at the end of the resection in a case in tumoral cases. As an example, here we have a sort of artifact at the bottom of a cavity on B mode, injecting the microbubble because they can be used repeatedly. We can see an enhancement, so we know that this is still vital tumors. And also there are indirect signs, such as the disappearance of the draining veins. Here you can see a frontal glioma once with hypertrophic medullary veins. Once this is resected, we inject again the contrast for us removement assessment, and of course the tumor is not there anymore, but nor the draining veins. So there are also indirect signs that we can obtain. Of course, this is not limited to glioma cases. We can use it in skull-based tumors, for example, and in large cases such as this one. It's helpful when we compare it to the navigation, because we can localize the large vessels surrounding the tumor in the surgical field, which for, let's say, beginners can be very helpful. In vascular cases also is a very, of course, a very helpful tool, because it's we can perform a sort of an intraoperative angiography with the advantage of visualizing the lesion in depth. So this is synergistic to, for example, ICG, or because we can see the surface with ICG and the depth with microbubbles, but we can not only visualize lesions such as this aneurysm here. We can assess the perfusion of the tissue after the clipping of the lesion, or this is another example in a case of a spinal dural fistula. In some cases of focal cortical dysplasia, microbubble can highlight a sort of a hyperperfusion that occurs in these cases. And as well as in spinal tumor, they are able to highlight the lesion with us, I think, an advantage over gadolinium, because being a purely intravascular, the microbubble are able to highlight the tumor only, whereas gadolinium sometimes extravasate because of venous hypertension, and thus providing the impression that the tumor is more diffuse than than what it really is. There are also pediatric applications, of course. Microbubbles can be used in children. Actually, children, small children, when they are younger than 1 year, 1 year and a half, they have a natural window to the brain, which is a fontanella. And Dr. Wang in Philadelphia clearly showed that microbubble can be used to assess damage in hypoxic cases. And it can be used also intraoperatively. We perform contrast ultrasound in pediatric cases as well at our institute. It is important in order to standardize the use of ultrasound in general, specifically here in the use of contrast ultrasound, but in general to standardize the collection of data. And I think that multi-parametric ultrasound can really help us in that direction, because being able to collect quantitative data is probably easier than collecting impressions, although standardized. And this is, for the first time, a few years ago, the use of contrast ultrasound in neurosurgery was included in the guidelines of the European Federation for Ultrasound in Medicine and Biology. And of course, they recommended the use of contrast ultrasound in neurosurgery, recognizing also that there are limitations because of the few data available so far. As I said, it's possible to perform a quantitative analysis. And as a matter of fact, this is an example with contrast ultrasound, but also for elastography or Doppler, we can really measure and provide measurement. This is our time intensity curves performed on different regions of interest. So we can analyze the distribution of the microbubble in time in different areas. And this is a paper we published last year in Scientific Reports, where we showed that arteries have, of course, a high number of microbubble, whereas tumors and the white matter, they have less. But really, this was the first time that this was showed in the brain. And it is interesting also to note that different brain areas have different amount of microbubbles. And also, this can feed algorithms for artificial intelligence, and probably we can perform an histological assessment, an intraoperative histological assessment in the future. And comparing microbubble imaging to other imaging modality, in the future we will be also able to find non-invasive biomarker of microbubble distribution, such as MR perfusion, probably, which in turn will prove very helpful to plan microbubble mediated therapies. So this is the prosthesis Alessandro Perin mentioned that we are developing at Carlo Besta, which will hopefully move forward towards the use of ultrasound in a post-operative setting, because the idea is to perform ultrasound imaging across its prosthesis. So we characterize the prosthesis from an acoustic point of view, and we also show that across the prosthesis with microbubble, we can open the blood-brain barrier. So opening therapeutic options for with ultrasound guidance in the future. And I hope that neurosurgeon will take this opportunity and will appreciate this new approach. So, as I hopefully I showed in this presentation, contrast ultrasound is just one of the multiple ultrasound imaging modality that compose multi-parametric ultrasound, and really the complementary application of the different ultrasound technique is helpful and provides many information, and hopefully will be exploited to standardize the use of ultrasound in neurosurgery as well. Thank you for your attention.
Thank you, Dr. Prada, for this wonderful presentation. Now, before our last last presentation, we are having problems with the simulation platform. So, but we are trying to solve this. And now we would like to present Dr. Padayashi, who will present Intraoperative Ultrasound and Pediatric Neurosurgery, Hydrocephalus, and Chiari decompression. Dr. Padayashi is currently full clinical professor and head of Department of Neurosurgery at the University of Pretoria.
Thank you.
Please, Dr. Padayashi, go on.
Thank you so much, Mateus and Ricardo, for putting this together. It's really an honor for me and for us as a group, really, to be contributing to improving the uptake of intraoperative ultrasound in adult and pediatric neurosurgery, and like we've seen through the series of these talks, a whole spectrum of applications. So I'm going to focus on the pediatric stuff. I probably now do more adult stuff than pediatrics, but my initial experience was with pediatric tumors and hydrocephalus and Chiari deformity. So I would like to share some of my experience with that. So this was mentioned previously, but I think it's always worth just reiterating the fact that even though ultrasound as a diagnostic or navigation or intraoperative tool has now migrated very much, in the fields, or at least advanced in obstetrics and cardiology and emergency medicine, the first medical description of the use of ultrasound was by Carl Theodor Dursig, and he was a physician who was, and his brother was an ultrasound, or at least a nuclear physician, who they used ultrasound to try and delineate the brain through the skull. And this is the image they first described. And if you look at it, it's very similar to a ventricle. They thought they were, visualizing a tumor with the ventricles. Turns out that it wasn't actually, it was more artifact than truth, but still the first description was to delineate the ventricle in the brain tumor. And like I said, since then, Ian Donald is credited with really driving the development of ultrasound after having pioneered its use in obstetrics. But I think recently that curve is starting to tip more in the way of neurosurgeons and back towards how we can use it, and that's really because of the advances in the software, in the probe technology, the size, and the image quality, which is perhaps the most important thing apart from the user variability, which is what, as you'll see from some of the previous speakers, what we've been trying to do as a group, improve that sort of user expertise, which I think is fundamental to improving the quality of imaging. So just briefly, I thought it's worth just outlining the fact that ultrasound in neurosurgery has a huge diagnostic component. And I've spent quite a bit of time, describing the use of non-invasive ultrasound as a non-invasive diagnostic tool for raised intracranial pressure. And in the context of intraoperative ultrasound, we've seen, the use in tumors, vascular surgery, and I'll highlight some of the uses in hydrocephalus and Chiari malformation. On top of that, it's also important to bear in mind that our basic CEUS and Pieter neurosurgery are all sort of ultrasound-based tools, and then advances like was demonstrated by some of the previous speakers, things like 3D ultrasound, contrast-enhanced ultrasound, which is becoming, advancing in leaps and bounds in terms of its applicability, strain and elastography ultrasound, the shear wave as well. Then there's a therapeutic modality like Francesco demonstrated, high intensity, briefly really, intensity focused ultrasound in the context of tumors, functional neurosurgery, and then opening up the blood-brain barrier. And then really a very sort of small but emerging promising research modality is neuromodulation using sonogenetics. So as a bedside diagnostic tool, I think in pediatric neurosurgery, we're all obsessed with decreasing the amount of radiation that we expose the developing brain to. So we want to decrease the amount of CT scans, and I'll demonstrate the use of that just now. But the benefit of a diagnostic tool there would be an initial or earlier diagnosis as a screening tool in neonates, for following up assessment of ventricular size, that's either post-VP shunt or endoscopic fenestration, and then POCUS, or the point of care ultrasound in the emergency department. There's been an explosion. In fact, the ultrasound almost replaces the stethoscopes, and I'm going to show you at the end of this talk how that is almost biblical in terms of its prognostic value in time. And you can see the quality of the images like has been shown in previous talks. This is a coronal showing the midline. You can see the ventricles, the choroid plexus, third. If you flip that same probe into a sagittal plane, you can see all the way down to the brainstem. And this is what the optic nerve sheath diameter looks like, which I'm briefly just touching on as a marker of raised ICP, something we've been doing routinely now for all forms of raised ICP, but particularly in brain tumor surgery, pre and post-op, and then as a follow-up screening tool. So I mentioned the dose of radiation. It's important to realize that even a chest X-ray is the equivalent of 1 day's background radiation. In a child, this is incredibly important. If you move to a skull X-ray, it's 5 days. CT scan is the equivalent of 8 months worth of background radiation. So a CT scan, one CT head effectively is the equivalent radiation exposure of 100 chest X-rays. And we know from literature that at least a third of children who pass through a pediatric neurosurgery service will have had 3 CT scans. And a study published in 2012 and also made the front page of the New York Times looked at 175,000 patients, and they showed unequivocally that a child under the age of 15 who has 2 to 3 CT scans triples the lifetime risk of brain cancer. And if you increase that to 5 to 10 scans, the risk of leukemia also increases. And I show this, this is a typical pediatric hospital where a child with hydrocephalus will have multiple CT scans of the brain to evaluate the ventricle size. And if you look at this, a 6-month-old scan, a child really, 15 CT scans in 5 months from the data I showed you previously, you can just imagine what the cumulative radiation dose is. So because of that, things like image gently, the evolution of the use of ultrasound becomes so much more attractive, particularly in pediatric neurosurgery. And like we've seen from some of the previous talks, the modern neurosurgery theater is an incredibly complex place. Imagine a first-time medical student walking into the theater we've become so used to now. The navigation systems, which are frame or frameless based, minimally invasive techniques, microsurgery, endoscopy, endovascular techniques, novel ablation techniques like the laser, high intensity focused ultrasound, the intraoperative image guidance techniques, or the structural monitoring techniques range from MRI, CT, fluorescence guidance to ultrasound, and then our neurophysiological or functional monitoring techniques, which range from mapping to monitoring techniques. And it's important to realize that neither of these function, as kind of isolated towers, but we should develop ways of finding means to augment their function and really improve the layered use of structural and functional monitoring. Ideal navigation technique we've heard previously is accurate, it's reproducible, it's dynamic in real time in terms of its feedback. Most importantly, it's easy to use and reproducible. Portability is a great feature. If it's cost effective, that adds benefit. And in children, if it spares radiation exposure to the developing brain, I think that's really, really a useful attribute. And ultrasound really ticks all of those boxes. So in my practice over time, the evolution of the use of ultrasound has been, from the initial ventricular catheter placement. I use it now routinely for virtually every single tumor that I've done, for complex endoscopic fenestrations and catheter placement in multilocular, cystic or complex hydrocephalus, for vascular lesions, adults or kids, Chiari-1 deformity I'll show, and routinely with a different probe for the intramedullary spinal cord tumors. The necessities have been mentioned previously, so I'm not going to belabor that too much, but you need a proper dural window, you need a sterility sort of protocol that you can enforce by repetition. Image quality, you've got to optimize, that's really the software, but also user variability. You've got to familiarize yourself with the image display because it's not intuitive for neurosurgeons, the type of probes, and really that's where the big contribution has come in. The quality of the probes in terms of the imaging is improved and the size has decreased. So really all you could ask for. And then user experience, which we've emphasized, and we've driven this now as a group, trying to build, these courses and teaching in a structured way, more and more. The types of probes we've heard, they're generally the burr probe for catheter placement. You can see something, I think at the moment, as I understand it, only BK have, but there may be other companies, so I may stand corrected there. Your high frequency probes, they're really just the phased and linear array probes and slight variations of these. What's probably been really interesting, more so in the emergency unit than in intraoperatively, is the portable handheld units. And these, you can see the quality of images you can get off a mobile phone or a tablet. And there are a number of companies now focusing on this, this particular value proposition. And for me, that's incredibly promising that algorithms and machine learning are focusing more and more on ultrasound images. So this is the case I like to show It was a 2-year-old kid at the time who had this horrible, what turned out to be an ependymoma, a grade 2 ependymoma. And you can see it was a diffuse, almost a hemispherical tumor. And I did what I thought at the time was a pretty good resection, respected the ependyma, removed everything I could under the microscope. I didn't have the ultrasound with me at the time. So it was just navigation. In the follow-up scan, while it looked good, you can see there's an area there that perhaps, I was not that happy with. The follow-up radiotherapy scan showed that there was residual tumor there. We went ahead, gave the kid radiotherapy and a chemotherapy regimen actually. But the point being, if I had my intraoperative ultrasound at the time, I would probably have picked this up and have removed it completely. So the important things to look at when evaluating a tool like ultrasound, like we've heard, is localization. And you look at this. This is the MRI scan coronal. You can see the quality of the images are just spectacular nowadays. Again, navigation, intraventricular tumor. You can see to what extent you can identify these lesions, accurately. And in some instances, the ultrasound, and more often, I think now, as you become more experienced with it, it becomes even more valuable. So this is a choroid plexus tumor in the lateral ventricle extending into the third. You can see the lateral and third ventricle component, but that little scanty blood vessel becomes so much more visible when you use the Doppler function. And as you use this continuously intraoperatively, you know exactly where the vessel is, and you can make more of an effort to preserve it. And I'll show in a slide shortly how you can identify tumor vessels separated from adjacent vessel that supply normal tissue. So in pediatric neurosurgery, the bulk of tumors we take out are in the posterior fossa. And my experience has been that the imaging quality for posterior fossa tumors is perhaps even better than supratentorially. So this was what turned out to be a medulloblastoma. You can see if you compare the imaging quality on the MRI to the ultrasound, it's really very comparable. You can see the solid component, cystic component. During the resection, I removed most of the tumor, but was unsure about the kind of boundary or infiltration. But ultrasound suggested there may be more tumor along the boundary, which I then resected. You can see a nice clean floor all the way down to the aqueduct, and that's confirmed by the intraoperative ultrasound, which gave a really nice, clear image. And it's incredibly reassuring, when you have that sort of thing. So for cases where there's a, complete resection, that's what the tumor looked like. Intraoperative ultrasound resected it completely. You can see here it becomes a little difficult, when there's change, so intraventricular tumors and this collapse of tissue, but certainly I was happy that there was no tumor left there. And this was confirmed on the post-op MRI scan. So again, very reassuring. Again, a complete resection you can see here. That's, I layered the kind of Surgicel afterwards. The intraoperative imaging just before I placed the Surgicel showed a nice clear cavity, confirmed on post-op MRI. So what about, intraoperative residual? So this was a kid who had a tumor that had infiltrated the brainstem, and our monitoring suggested, or at least the interpretation suggested, and the hemodynamic stability of the kid, I chose to leave that bit of tumor behind against the brainstem. You can see it there. So I saw that, and you can see on the intraoperative ultrasound, I knew exactly how much tumor I'd left behind. So when I did the post-op MRI, it wasn't, a surprise. So at least it prepares you, and the kind of correlation between the ultrasound and MRI scans are really phenomenal these days. Tumor in the spinal cord, you can see what it looks like on the MRI, beautiful delineation with the hockey stick probe. So you've got to use a very specific high resolution, small footprint probe. And I've become quite comfortable with the hockey stick probe. You can see we resected the tumor there. This is just a collapse of tissue, but the follow-up scan show we removed all of the tumor. Then the vascularity, you can see, so there is some loss of resolution when you image. I think maybe, Francesco Prada could add more information about this, but even with the contrast enhanced ultrasound, as with the Doppler or vascular imaging, you tend to lose a bit of kind of basic resolution. So you can see that's what the tumor looks like with the Doppler here. But as you want to image the vessels within the tumor, you can see that's tumor vessel there, and these are adjacent vessels, the pica on either side. So it's quite nice after you've removed the tumor, just to make doubly sure, image these vessels, see what the quality of flow is before you close up. And with the Doppler functioning, I mean, we're using it more and more in its research capacity. You can see the quality of flow you get here. This is a vein of Galen malformation. It's really, really useful, you know, in picking up deeper seated vessels, and depending on whether you use the power Doppler or just the Doppler function, you know, you can pick up flow direction or not, and actually quality of flow. Okay, so intraoperative ultrasound, post-op MRI, I think this was mentioned previously, but the correlation is really better and better, and more studies coming out recently suggest this excellent correlation between what you see on the intraoperative ultrasound in terms of residual tumor or degree of resection, and post-operative MRI is pretty good. So hydrocephalus, we saw briefly from one of the previous talks, you know, placing a ventricular drain. So I started out using the ultrasound in kids with an open fontanelle. I love using this. Is one of the earliest pictures I use. So just to stop there quickly, that's anterior, this is posterior, so frontal occipital. This is a sagittal image, and we're placing the catheter coming in here. So there's no other imaging modality that allows you this degree of real-time imaging. So you can place this catheter under absolute real-time guidance. And you can see as I get to my desired point at the foramen there, I just flip the probe from a sagittal to a coronal plane, and when I thought I was more medial, turns out I was more lateral than I thought. So you can always correct that. And again, I'll echo the point that there is no other imaging, you know, modality that gives you that real-time feedback. So we you know, conducted a study comparing objective and subjective evidence of catheter placement, and looked at, you know, how that impacts on shunt survival. We used these criteria by Hayhurst and did this together with Martin Schumann. And we found that under ultrasound guidance, there was a big difference between optimal placement. So you could place them better. The acceptable group as well didn't make too much of a difference. So it was better quality of placement that we had a higher group of. And if we looked at need for revision overall, remember, ultimately the need for revision of a shunt catheter or a shunt is not just the ventricular catheter, but the distal catheter as well. And this study, so you know, came out quite strongly in the one paper. The recommendation was that ultrasound-guided ventricular catheter placement should become standard of care in VP shunt surgery. The pediatric hydrocephalus group from the HCRN network included this in their recommendations, and their recommendation was that the routine use of ultrasound-assisted catheter is an option. So the strength of their recommendation was level 3. So somewhere between these two, you've got to find a place that really works for you, but certainly there's more and more evidence supporting ultrasound guidance for placement of ventricular catheters. So neuroendoscopy is something I've also spent a lot of time with, and I've combined the ultrasound together with this, but you know, the experience with this completely predates mine. Image-guided neuroendoscopy is really standard in, I think, most centers doing endoscopy, and whether it's, you know, stereotactic guidance or real-time imaging, I use both of them. So I always plan beforehand the entry point and at least 2 targeted points. The difficulty here is as soon as you insert your scope, the navigation becomes virtually useless and the ultrasound needs to take over. So you've got to use them in conjunction. I know some do argue in little kids, why use navigation at all? I've just preferred using it, you know, for that added safety of planning the trajectory. There have been quite a few publications now supporting the use of navigation in endoscopy, with one from Israel stepping this up and saying that, you know, you need some form of intraoperative imaging. They use the intraoperative MRI. It was in 5 infants, and I'm you know, good friends with the team here, and they've also subsequently moved away from using the intraoperative MRI. I found it, you know, it's useful for some things, but in the context of CSF management for these complex cases, the ultrasound is probably more useful. I've included this here because the quality of your outcome here depends on kind of the ventriculography. And this paper by Gendoki suggested that MR ventriculography is a useful tool where you inject contrast into the ventricle. You can see there communication, no communication, so they know this hasn't been adequately fenestrated. The difficulty here is that you can only do it pre and post-op, so you can't actually change your intraoperative plan. And I'll show how we've developed a technique that allows us to alter our plan by using an ultrasound type ventriculography. And we're really sort of encouraged by this study, you know, at least our thought process was stimulated by Stravitsky's study back all the way in 2002, where he found ultrasound-guided endoscopy was safe, gave you permanent visual control, real-time imaging to check the position of the tip, and he used the saline flush technique, which we've really advanced on now, and found it incredibly useful to confirm that we've adequately fenestrated. So this is typically what the setup looks like. And these complex cases are always the nightmare of any pediatric neurosurgeon, working out exactly the best way forward and how many times you've got to go back and whether you place a ventricular, subgaleal, multiple VP shunts. And, it's a complex decision-making curve. So we combine the ultrasound with our endoscopy. I use a 6-handed technique. So I've always got 2 registrars who assist, one with the endoscope, one with the ultrasound, and one with the aspiration. So this is what our ultrasound ventriculography technique looks like. You can see the endoscopes in there. We use a ventricular catheter to inject. I've moved away from the term microbubble because it's very specific in terms of, like you would have heard Francesco previously, but we inject a sort of saline flush, effectively causing these small little bubbles, and that's what it looks like under the endoscope. You can see here, this is a sagittal plane. So we fenestrated one locule, but we weren't sure whether we'd open the other. So we inject the saline flush, and you can see this contrast ventriculography really surrounds that, which basically doesn't go into the cyst at all. So we know we hadn't fenestrated that, and we could then go back and open it up at the same, within the same procedure. So we've We've written this up in the WFNS guide for neuroendoscopy, and the chapter kind of detailing the use of ultrasound guidance in ventricular endoscopy. And you can see what it looks like without, any sort of ventricular ultrasound contrast there, just getting imaging. And here's a flush technique. You can see it runs all the way down to the third, all the way onto the lateral ventricle on the other side. So we know we've done an adequate job by communicating the ventricles. In terms of Chiari deformity, all of you, I'm speaking to a crowd who understands this, as well as any. There are a number of definitions of what a Chiari deformity is, malformation. The terminology differs, but effectively, you got to select the group out properly. I use a cine MRI scan in part of my protocol where I use the ultrasound. So in cases where there's CSF flow, no CSF flow demonstrated across the CCJ, and I think it's purely, bony decompression that can be used. I then use the ultrasound here. You can see the bones being removed. This is the patient lying prone. That's the dura. This is the tonsil. So just that pulsation has been described by some as enough to accept that you've adequately decompressed. But if you use the Doppler flow, you can see, I like to see flow around the decompression. So restoration of flow, where I've demonstrated no CSF flow on the cine MRI scan, I would then consider a bony decompression adequate. And we've done now about 25 of these cases, and largely it's been, that sort of thought process has been supported. In cases where, more complex cases where you've got a sort of tonsil herniation with a syrinx, here I've actually opened the dura and we've cauterized the tonsils. You can see that again, patient prone, that's the tonsils. This is the cord, that's the syrinx. Just the ability to image the syrinx with the ultrasound, that quality of imaging. You can see the pulsation. I'm clear, I'm happy, that's open, there's CSF flow here. We then decompress the syrinx. You can see the cords collapsed completely. So these are things you can only do with an intraoperative ultrasound. And apart from the obvious benefits I've shown, these sort of quality assurance checks are really the value of using the ultrasound for this procedure. And then, like I mentioned, it seems as though the ultrasounds replaced the stethoscope in at least emergency medicine. And it's interesting that if you go back all the way down to 1823, when J. Forbes wrote this preface to Lennox Treatise, he said that, to quote him, he said that it will ever come into practice, and general practice I'm extremely doubtful, because its beneficial application requires much time and gives a good bit of trouble to the patient and the practitioner. And at the time he was talking about the stethoscope, 1823, and we know how widespread that's become. And for me, it's almost predictive of the path or the trajectory that ultrasound will follow in neurosurgery and in medicine in generally. You've got to take the time to learn how to use it correctly. But once you implement it, I think it will become as standard for us as the stethoscope has become for other general practitioners. So to summarize, then, intraoperative ultrasound is safe, it's cost-effective, portable, non-invasive. It has diverse applications in pediatric and adult neurosurgery, diagnostic, navigation, surgical adjunct, and like I've shown, therapeutic and neuromodulation in a research capacity. It's an incredible value proposition, I think, in neurosurgery, and certainly worth making the effort to integrate this into our routine practice. And like we've seen, our team has now conducted so many of these pretty much around the world now, and Gaman Ungsgaard has spearheaded that, really driven the interest in the educational profile of ultrasound in training and training in neurosurgery, and we hope to continue with that. I also want to just take the opportunity to welcome all of you and at least let you know about the 18th World Congress of Neurosurgery that we're hosting in South Africa next year in 2023. So please save that date. It would be great to get as many Latin American attendees as possible. With that, I thank you.
Thank you very much, Dr. Padayash, for this presentation. Wonderful, as all the previous one. Let's proceed to our discussion session. Thank you again, everybody. I'll call Ricardo de Oliveira to proceed with the discussion. Please, Ricardo.
So thank you so much for the special lectures that you present for us. It was remarkable. So thank you again, Germont, when you invite me by email to organize this webinar. I think that was very interesting points that you present for us. I have a particularly history involving ultrasound because my PhD thesis was using ultrasound and hydrocephalus. In fact, Doppler ultrasound to follow children with shunt malfunction. So we use this, and until now, I practice ultrasound in my routine day, even for the bedside ultrasound and even intraoperative ultrasound. And my first point that I would like to listen all the speakers is about how, in your view, how do you think that the neurosurgeon accept more today the ultrasound than in the past? So ultrasound became more popular, in your opinion, than 10 or 15 years ago. What is your opinion, your particular opinion about this topic? How difficult is to neurosurgeon accept or to do or to practice routinely ultrasound?
I can say something about it because when I started with navigated ultrasound in '96, I was invited to different congresses in the first decade of 2000, and of course I realized that the interest for ultrasound was not that big at that time. Also, intraoperative MR was very much hyped in a way. Peter Black had a lot more, a much bigger audience than I had with the intraoperative ultrasound. And of course, that could be due to different things, but mostly I think it's due to that neurosurgeons have to learn something. They have to take on some responsibility to be able to use ultrasound. It's easier to use intraoperative MR because then you have a lot of people that are around you and can help you. But if you are going to use ultrasound, you have to learn it yourself, actually. And I also think it's because the increased use of ultrasound now is because the quality of the ultrasound has improved quite a lot, and there are also more possibilities for learning. But I think we, as a group that have been used to ultrasound and is trained, has experience in ultrasound, should especially aim at the younger group of neurosurgeons for teaching, I think. I guess that is, it could be different opinions about it, but as I see now, there is a real increase in the interest for ultrasound. that wasn't there for 20 years ago, or maybe not 10 years ago. So I'm really enthusiastic about it.
Yeah, I would say not only is an increased interest, but I think the younger generation is just naturally inclined to use it, especially if you learn it earlier. You know, one of the most important aspects of it is, as Alessandro was mentioning, the moving from axial coronal sagittal to somewhere in between. And once you pick that up and you keep using it, I find it's incredibly intuitive, but it definitely takes a little bit of a hurdle. But I have to say, as German was mentioning, the acquisition of it in the younger generation just seems very, very natural. And it's very exciting to see.
Yeah, I agree with what you said, both Brian and Germund. I think the industry plays a role. Actually, one of the issues for ultrasound is that industry is not playing a role, whereas in the past, intraoperative MRI was pushed, and probably the economics was much more, the interest were higher. Also, one of the issues for ultrasound in the past, the image quality was really bad, whereas now the resolution has increased. It's comparable to MR, I think, and it's better in time resolution because it's really real time. So one of the issues is probably having a good machine and exploiting it most, and having courses, because as we know, ultrasound is not a diagnostic tool, so we cannot plan our surgery relying on ultrasound. You have to sort of improvise in the OR, and you need training, and this is why we put this group together, in order to train people and know what to do in the OR.
Yeah, it's interesting how the neurosurgeon accept more the neuronavigation and also the MRI, the intraoperative MRI, and we know in developing countries it's very expensive to have or to try to have a MRI in intraoperative MRI. So it's almost impossible for many neurosurgery institution, and the neuronavigation is more acceptable for the neurosurgeon. It's interesting. I think that probably, I don't know, but the association between ultrasound and neuronavigation is, in my opinion, is much better to improve the quality of our resection, and even doing some biopsy, some guide biopsies using this tool, neuronavigation and ultrasound. Another point that I would like to discuss is using the contrast for improving the quality of brain resection. How is the price of the contrast, using the contrast? Do you know the price, how you add, how much is the price of the contrast?
Are you talking about the intravenous contrast?
Intravenous contrast.
I think that would be Francesco Prada to tell. You are muted, Francesco.
Yeah, I briefly lost the connection, so I missed the last 30 seconds. Sorry.
Did you hear the question, Dr. Prada?
No, I didn't. No, because I lost my connection was lost. So
okay, we are talking about the price to using the ultrasound contrast, intravenous ultrasound contrast. How do you know how much is?
So you need to use like one or two vial. It comes in vial per surgery, and it's around $120 per vial.
Mhm.
Of course, as I mentioned, you need a machine that is capable of visualizing the microbubble.
Okay.
And but high-end ultrasound machine with integrated navigation are less than $100,000.
Mhm.
So I don't know, it's much less than a navigation system alone for neurosurgery, in Italy at least.
Okay.
So, and there actually, Alessandro and I, we work in a neurological hospital, so we don't have a huge ultrasound department, but if you work in a general hospital, for sure they have a last generation ultrasound machine, and you can discuss with the radiologist, and they use contrast daily because it's the gold standard for assessing, for example, liver tumors or other kind of diseases. So it's the gold standard now. And you mentioned, sorry, I want to add something. You mentioned developing countries. For, I think this is an opportunity for developing countries because ultrasound is really, as we said, cheap, and there are also now portable ultrasound probes, and I think in terms of cost, ultrasound is unbeatable, and this is the moment to spread its use, probably.
Yes, perhaps I want to just add a point there, Ricardo, to add to what Francesco is saying. You know, we often get asked this, you know, is ultrasound useful in the context of, you know, whatever one wants to call third world or developing countries, Africa, India, Southeast Asia. You know, just to go back, one point I meant to make as well, despite all of these advances in software and, you know, image quality and all of that, one needs to bear in mind that if you plot the evolution of ultrasound, yeah, things have become better, but sequentially, there've always been improvements. And if you listen to Victor Hugo's quote, you know, there's no more idea more powerful than one whose time has come. You know, it just is the right time now, and you need people to drive this, you know, and as a group, we've done that, and or at least are trying to do that. And you've got to accept that, you know, it's the right time, you know, that people will accept it just because of where it's positioned. And we often get asked this question, you know, can I use the ultrasound machine that is in my, you know, ultrasound department or in the, you know, in the emergency unit? And, you know, initially I sort of steered away from that, but the more and more you get asked that question and realize that, you know, you should encourage people to use it. The more that they become used to it, the better they become, you know. And if you're buying a new probe, again, like was pointed out, it's a lot more cost effective than having to get a, you know, a navigation system or whatever the alternative is.
Okay. Ricardo, do you have some question?
A question for our audience here. Let's see this minute. Dr. Leonardo Rocha Carneiro Zapata, any recommendation for posterior fossa tumors? Would it be possible to use in a retrosigmoid approach? Doctor?
Yes, even in the sitting position. Not really practical, but it is. I think it's.
I have used it in acoustic or schwannomas in the intermediate nerve, and it's useful because you can know at any time how much tumor you have left. It makes it easier to do the resection a little bit faster, but of course. You have to be very careful about the facial nerve anyway. So you need the stimulation to know where you have the facial nerve. But it's helpful to know the how big, if you have a very big tumor, to feel safe when you are doing part of the resection. I think it's useful.
I have a question for Dr. Padayash. Do you have experience in ultrasound for septostomy, to like a isolated lateral ventricle?
Thanks. Yeah. So I think in the context of fenestrating complex, a hydrocephalus with multiple compartments, we probably have fenestrated a septum. I don't think it would be too much different to the process that we would use in complex multiloculated hydrocephalus. For just an isolated lateral ventricle where you need to do a septostomy, it's probably less useful because you fenestrate one membrane and you can see across into the other ventricle. So you've done the job, but you can for sure. But I think the value proposition is higher in where you've got these isolated cysts that you want to make sure that you've fenestrated adequately.
Okay, so Ricardo, do you have some question or comments?
Yeah, I have a comment. I think here in Brazil, I don't know your country if it's the same, but here in Brazil, one of the problem is to have the integrative of ultrasound and MRI, and neuronavigation systems. It's just not that you have just one machine here in Brazil that do this. So the prices is 2 or 3 times more expensive than the normal ultrasound. The other problems is the softwares that you have to buy the softwares too, and this is increase the price too. So, and then most of the insurance companies don't pay for that. This is a problem for us here. So I use a normal ultrasound, but the integrative solution with the neuronavigation sometimes is limited because this plus in prices for us. Probably we have to fight to have more free softwares or free licenses to do these integrative systems more available for everyone. I don't know if you have the same problem in your countries, but I'd like their comments.
Yeah, and another point is just my final remark. It's another point is how the neurosurgeon like to perform CT scan instead of ultrasound for new babies, for premature and new babies. It's incredible when you see the number of CT scans that we request for children instead of to use ultrasound just to follow a simple case of macrocrania, or as Padayashi showed in his presentation, hydrocephalus, or some easy problem that you can follow with ultrasound. And so I think that these points, the problem with the update in terms of the ultrasound machine, the price, in some case, the neurosurgeon accept this tool in his practice. So these factors are important to change the behavior of the new generation.
I have a comment to the last, the previous speaker. I think these navigations companies that have equipment that can be put on an ultrasound equipment, it's far too advanced, too much features. What you really need in the navigation of ultrasound is rather simple and certainly doesn't need to cost that much. So I really hope that pretty soon either some ultrasound company could add a navigation to their probe in a way, which is integrated, just the way I had at my machine that I used for many years. So the one that was ultrasound and integrated navigation, and and it's possible to produce that much cheaper than adding a navigation system to an ultrasound machine, because you have so much extra in the navigation systems that you probably don't need.
I mean, if I could perhaps just add something to that in support of that comment. I'm not sure how many of you are aware, but recently GE Health, which is a behemoth company, bought out BK Medical. I'm not sure if you know that. So I think they spotted the potential. I mean, BK really cornered the market in neurosurgery. And now GE have bought them out like completely. And they're looking at partnering, as I understand it, I stand corrected here, but with Medtronic. So I think what you're saying now is exactly how this is going to play itself out. And I think, I'm just going to make the same point I did earlier. Sometimes things happen because it's the right time for them to happen, So with GE buying out BK and, looking at partnerships with the navigation companies, I think exactly what you say. We'll watch this space and see if it plays itself out like that.
Okay. Okay, Matheus, could you explain the next part of the webinar?
The next part of webinar is the simulation with Dr. Alexander Perrin using unfortunately the website is not working today, but Dr. Alessandro, can you explain about the simulation?
Absolutely. So the website is working. Indeed, we have experiencing a technical problem with the registration process. So I hope that some people managed to register in advance when we sent the advice yesterday. I don't know what happened, but indeed, people cannot register today. So as a matter of fact, I think I'm going to present and give you some basic instructions about how to simulate intraoperative ultrasound by yourself. So you can do it in the privacy of your house, on your sofa, in your office, anytime. So just you can watch this registration in the future. And for the upcoming next 2 weeks, you will be granted permission to access the website and simulate for free. So do not worry. Just follow me with these basic instructions. As I alluded before during the other presentation, we created this app that can be used by your smartphone and laptop. And basically it allows you to have preoperative navigation and intraoperative ultrasound combined together. And as you can see here, you can transform your smartphone into a real intraoperative probe. And you can see the way you move it, you bend it, you tilt it, you can move it consistently on your laptop. And so basically all the movements of your head can be transferred to the computer. So this is the rationale. And this is the case that you will be allowed to work on. So it's a right frontal solid and cystic metastasis. So you can see some structures here like the folds, like the cyst, the solid part of the tumor. And also look at the sagittal section. So you pay attention to how the tumor looks like basically on these two sections, as we discussed before. So coronal and sagittal sections are very important here. So instructions are very simple. So you need to disable the auto lock function on your smartphone. So it's very simple for an iPhone, but also for Android. So you enter display and brightness, and you set the auto lock to never. So that's very important. So once you do that, you log in on Neurostream Academy. And in order to do that, you need to register beforehand. So now I'm talking to those of you who managed to do that yesterday or during the days before. You enter your username and your password, then you log in. Once you log in, you click on US simulation here. You scroll the web page and you click here, top left case. So it's this right frontal metastasis, the one that I just showed you early on. So once you click on it, you have these three options, okay? You click on the right option, the learning mode, the green one. Once you click on it, you need a password in order to enable it. And the password is this, very simple. So new, caps lock, IoUS 2022. So I show you again so that everybody can write it down. So new IoUS 2022. And then you click on enable. So once you do that, you have to pair your smartphone to your laptop. You're gonna be seeing QR code. You aim at that with your smartphone, with the camera of your smartphone, then you click on this link. And basically it's all a following consecutive steps that you have to follow. You click on the screen, whatever it's gonna ask you to accept, like to allow your camera to do that, your accelerometer to track your movements. So again, so QR code, then you allow US app, then you tap here. Once you tap there, you get that green check. And when you put your smartphone in front of the screen of your laptop, you should be able to see a series of movement that would be replicated by the virtual probe on the screen of your laptop. Have a look at that. So you see, now you're moving your smartphone and the probe is moving consistently. So that's very important. Once you manage to do that, which is automatic, so it's super easy, you're able to go on and continue to simulate. So you will be automatically directed to this page, which is the US learning mode of neurostream.academy. Basically, you will be seeing this. So you are here now. So step number 3. So you start with ultrasound only. So now it's like if you had a real ultrasound probe in your hands. And that is positioned on the dura mater right on top of that tumor that I show you. So it's a right frontal metastasis, which is cystic and solid. You will be asked to outline some of these structures. Basically, there are 10. And this task will be asked you also afterwards when you will combine ultrasound with preoperative MRI, so coplanar matched images. And at the end, when you will be seeing intraoperative ultrasound only. So the bottom line of it is we want to see how fast you can improve your intraoperative ultrasound skills. And you will be impressed by that because we published that just by one application, you can go up to 100% in your ability of recognizing both normal anatomy and pathology structures within the brain. So how can you do that? So you move your probe, and once you see the section that you think it's the right one that allows you to see, in this case, the cystic component of the tumor. So you click on outline, and then you have these 3 functions here. So you can draw the part of the tumor that you think is the right one. Once you're done, you click on check or on the X, whether you want to go back and draw again and start again, or start again and move your probe and go back to the simulation part again. So it's very simple. You will have 5 minutes for each one of the steps. And believe me, it's more than enough. So once you are done with one part, you will be automatically redirected to the following part. So in other words, that's the summary. So you have 5 minutes for intraoperative ultrasound only. Then you have other 5 minutes to go through all the 10 landmarks. But this time you have the help of the preoperative MRI, which is matched, it's coplanar with intraoperative ultrasound. And then the final step, it's the validation, the final check of your test. You will be asked to find those 10 landmarks relying on intraoperative ultrasound only. Once you're done, you will get a report. It's a PDF, and that report you can send it to me. So you can send an email to me. That's my email. So aperin@gmail.com, or you can post it on neurostream.academy, because now that you have your credentials, you have full access to the website, to the platform. So you can use it as a social medium. So feel free to post it, and we can discuss your results together. So again, remember the password that you have. If you didn't manage to register yesterday or during the previous days, you can do it either tomorrow or for sure on Monday. Just give us time to fix the problem that we are experiencing with the registration form. I do apologize for that. I don't know what happened. It never happened before, but don't worry, because in the upcoming 2 weeks, you will have a chance to do it, to try it yourself, and then post your results either to me on the website. So thank you for your attention. As you could see, it's super easy. Feel free to use it. Don't be shy, and spread the rumor with your friends and with your peers. Thank you.
Thank you, Dr. Perin. This video will be available at our YouTube channel. Please, everybody, subscribe so you can see this video and other classes and lots of stuff in SBN PED channel.
Fantastic. It's really fantastic tool that you can practice. So it's very, very nice. Did you, talking about simulation and education tools to learning ultrasound, how's your opinion about the new tools, for instance, using models, how can I say, the phantom models, or 3D simulation, and using app for 3D simulation and brain and ultrasound? How's your opinion?
Well, I think that, like some other speakers already mentioned, there's no standalone trick or way to become a master in intraoperative ultrasound. So it's always a combination of things. For sure, spending time in the OR is very valuable, but especially when you are a beginner, you need something beforehand in order not to waste time in the OR. So like this tool, like simulation, is excellent because you learn the semiotics of intraoperative ultrasound beforehand. So you know what you're going to see in the OR. As you said, phantoms are great. So we use that at our courses. And as a matter of fact, now in Milano, together with the physics departments within a project that was funded, and it's called PrintMed 3D, we actually developed some phantoms that are made of some, they're made like 3D printing process made of silicon, and they're extremely realistic. So I didn't present that because that was out of the purpose of my talk, but they are extremely valuable because they're realistic. They have a nice arachnoid interface in between the tumor and the normal brain. Plus, they have all the features of the parental tumor. So those are cases that we have operated on at Vesta. We endow those phantoms with all the navigation information. So once you put your phantom there, you can use intraoperative navigation and see where you are inside the tumor. Plus, and this is something we are working on, it's not there yet, we would like to have the possibility to combine the pre-acquired intraoperative ultrasound data, so that when you put your mobile phone there, you can simulate that. Plus, we are working also on the physics characteristics of the phantoms in order to allow the resident or junior participant to actually see the real features of intraoperative ultrasound because of the physical characteristics of the phantoms. This is something we're working on. But I agree, I mean, having a phantom is also another very important and useful tool.
Thank you. Other comments? Mateus, Lewis, Ricardo, Germund. So as you said, we will have the open access to the Neurostreams website, and you can register later to practice for everyone.
Yeah,
Yes,
absolutely.
and you can review this class when you are registered to simulate at your home, at your sofa.
Yes.
Yeah, I just posted the password to you, Ricardo, so that you have it and it's spelled correctly as it should be. So I do apologize for that. I don't know what happened. It never happened before, but we're going to fix it for sure. By Monday, it should be okay, if not by tomorrow.
Ricardo, Germund, do you have to say some words and to close our webinar?
Yeah, I think thank you very much for giving us the chance to have this webinar in Sao Paulo. It's the first time in South America, and we are very thankful that you gave us this opportunity. And I hope it has been of some help to the people that have registered. It would be nice if we get some feedback about how they experienced the course and some criticism, how to improve it and so on. If that is possible from the registrars, that would be nice to have for later courses.
Yes, I hope that in the next future, in our meetings, our physical meetings, because now we are doing again our courses, our congress. Yeah. I hope that we will have a practice ultrasound in our national congress or other meetings. Ricardo, what do you think about? Because we discussed. Did you remember, Leo? We discussed in Birmingham about this in 2019, but unfortunately, because of the pandemic, we postponed our idea to have hands-on on ultrasound in our national congress. Ricardo, you are mute. Please open your microphone.
Sorry. Yeah, I think there is a lot of people now very interested in practice and learn about the ultrasound. I think this way to learn it's very interesting, but nothing is equal if you do personally and try to do it and do the programations and see which machine could be helpful for the surgeons. I think the next Brazilian Congress will be perfect if I have the opportunity to do a practical course about ultrasound. I think there is now a different way to see things and improve our results. It will be perfect.
Yeah, I think it's very important to have these courses live. That is what we strive to do, and to have hands-on with practical things to do with the machines and so on, learn the machines. I think that is important. So that is what we would really want to attend Brazilian meeting where we can present or where we can have this hands-on course with phantoms and so on, and in combination with the lectures as well, so that you get a broad learning of ultrasound.
Perfect. Probably in our next Brazilian Congress of Pediatric Neurosurgery will be here in Goiânia in August 2023. So let's think about to do something like that.
Yeah, we will aim for that.
Yes.
Good. Very good.
Okay, we can close, and thank you so much for the excellent presentation. And it was very nice for us. I think that it was the first webinar in this specific topic, and I like it very much. And I think that for the Brazilian Society was also very interesting to have all these speakers talking about this topic. Thank you. Thank you, Ricardo. Thank you, Guilherme.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.